clerk last year
Yeah.
till Jan,
Yeah.
and she had this supraspinatus tear. Earlier, it didn't present as a tear, but she had the supraspinatus pain, for which I gave
Okay.
her exercises, but obviously she didn't do those exercises. Then
Okay.
later, we tried her pain aggravated, so we tried giving her ultrasound and modified Pune shoulder rehabilitation protocol,
Okay.
which kind of took the pain down, but within a week, the pain again came back. So, and then again
Okay.
she also traveled abroad, and she had to carry her own bag and all. So, and after that, once she was back, her pain had gone up to almost 8 out of 10. So
Okay.
we we took her to Dr. Kamath, and then um, also her special test, like the MT can test, was positive. But
Okay.
at that time, even her drop arm was positive. So he suggested for a few anti-inflammatories, and then we went for an MRI.
Yes.
The MRI suggested only less than 50% tear and
Yes.
acromial spur. But when we went back to the surgeon, he told us that it is more than 50% tear, and the acromial spur is still there, and that is the reason for the tear.
Okay.
So then he said that we should plan for surgery.
Okay.
We wanted to wait, like she had some retirement work going on, so we had to
Correct.
wait for some time. And then the lockdown happened. But between that time, we also took Ayurvedic, of a few Ayurvedic medicines, and she underwent panchakarma and all that, because
Correct.
undergoing surgery at that time was not possible. So
Yes.
we thought of like going for collateral therapy if that works at all. Right now, her uh, this drop arm test is negative. Her MT and
Correct.
her MT can test is sometimes very
Correct.
painful. Sometimes the pain is less. I'm not able to understand whether the supraspinatus has started healing, or
Yeah.
I don't know in
So
which stage it is.
yeah, correct. So I love this question. I'll tell you why. Because this is the most common problem patients have. Okay, and this is the last requirement for a surgery. So always remember, this is exactly. I mean, has everyone been able? I hope everyone has been able to understand what she was trying to present with, and this kind of case comes to you in the consulting very often. Okay, so I'll give you some basic principles. Now, why would I tell you some basic principles? Is because this is how you look at shoulder problem. Number one, never hurry and operate inside the shoulder. Okay, always remember, when would you hurry? You would only hurry in some select scenarios. Now, I'll tell you which stage your patient is in. Okay, I'll just go back to the this and we'll have a discussion here. Is it clear?
Kai?
Hello?
Yes, sir.
Yeah, so now we'll have a discussion here. So this is exactly how your patient will have presented. Okay. Now, if you see in this MRI picture, you will see that this is the acromial bone, this is the subacromial spur, and this is the supraspinatus tendon. Correct. Now, if you see this supraspinatus tendon here has a particular whiteness, a hyperintensity inside the muscle, along with a lot of hyperintensity in the subacromial space. So this is a very typical patient with a partial thickness supraspinatus tear with a subacromial bursitis, right? So now what would you do for this patient? The classical thing what you do for this patient is try and reduce the bursitis. Do not insist on operating this patient. Even if the tear is more than 50%, it is not 100%. You try what I'm trying to get at. A 100% supraspinatus tear versus a 70% supraspinatus tear has its own indications for surgery. So whenever the patient does not have a complete tear, it has a definite chance of healing on its own. Correct? So always, what are the red flag signs which you need to keep observing for? Number one, stiffness. If the patient does not have stiffness, has a good range of movement, the patient is very comfortable. Number two, what is causing the pain? It is not the partial tear. It is the bursitis which is causing the pain. The patient had acute pain. She had gone overseas. She had lifted some back. She had caused a lot of friction between her acromion and the supraspinatus, and that is where she had developed bursitis. She had developed a lot of irritation in the shoulder, which had led to a severe pain in the shoulder. The pain must have been along from her neck up to the arm. and that is what is causing her uncomfortable movements. And on investigation, you would have seen that the patient has a partial thickness tear. So it was not the tear which was causing her problem, it was the irritation in the shoulder which is associated along with it. So for this patient, what you need to do is give her a simple Kinacort injection inside the subacromial space or in the biceps and supraspinatus along with the subacromial space. That is where you need to give her Kinacort to begin with. Maybe not now, maybe 3 weeks or 2 months earlier when she had an acute episode. If she's completely all right now, you can still wait. If the patient had presented to me maybe 3 months ago, I would have proceeded with giving her a Kinacort injection. What would it have done? It would have just reduced the bursitis. It does not heal the tendon. It only reduces the bursitis in the shoulder. But sometimes reducing the bursitis takes care of the pain, and it takes care of the pain for a very long time. So maybe after that, for the next 2 years, the patient was comfortable. I wouldn't have touched that shoulder for an operative treatment. I would have given the patient 2 more years. After 2 years, if the patient would have presented to me with the same size of tear, but with the same symptoms, I would have again probably repeated a Kinacort and asked the patient to gain 2 more years. Till the time the patient has tried at least 2 or 3 injections, the patient has developed a full thickness tear, the patient has developed stiffness, I would not operate the patient. Do you try what I'm trying to get at?
Yes, sir. I am getting what you're saying.
Hello,
But Dr. Kamath had given her a dose of Nucoxia for almost a month, and that reduced the pain, that reduced the kind of inflammation around the shoulder joint, which was coming from all the other muscles that were affected because of the underlying pathology. Yes. But then her this empty can test was still positive and still as much painful as the first time. So then he decided to move on to surgery rather than trying injections.
Yeah, always remember, I mean, from where I have learned and from where I have, at least been doing my fellowship from, we never moved in a patient with a partial thickness tear. We never moved from a oral analgesic treatment to a surgical treatment directly. We always had a Kinacort given in the middle. I mean, whenever patients in our clinics presented to us, they always used to have taken at least 1 or 2 shots of Kinacort. If they were not improving, then they would have undergone a surgery for a partial thickness tear. I'm again repeating, for a partial thickness tear, not a full thickness tear. Okay. So your patient, so there is always so do you know the concept of bioavailability? I always explain the bioavailability concept to my patient. So what does Nucoxia do? Basically, it's an oral anti-inflammatory. It goes into your stomach, gets absorbed into your system. The medicine which reaches your shoulder is 5%. With 5% medicine, sometimes the shoulder only temporarily subsides, but the pain does not completely recover. Okay, so even if your patient has taken a month course or maybe 5-month course of Nucoxia, the bioavailability has never reached more than 5% in her. You understand?
Yes, sir.
So the desired medicine has never reached the shoulder in that high concentration, and that is where a local intralesional steroid does its job. It just delivers the same anti-inflammatory effect as Nucoxia, but in a very localized area, actually reducing the subacromial bursitis, actually giving complete relief to the patient, and giving and buying us time before we decide to dive in for the surgery.
Okay, so right now her range of motion movements are complete. She's not trying a lot of internal rotation, but all other movements are complete. But there is a lot of scapular distance.
For her, yeah. So right now, if probably on examination she does have a lot of LHB tendonitis or supraspinatus bursitis, or still a little bit of stiffness, maybe painful range of motion, she can probably still undergo another Kinacort injection. Okay, she still has time for that. And what is the worst that can happen? I always ask a patient, like a patient presented, what is the worst that can happen with a single Kinacort injection? Can you answer this question? What is the worst what are you fearing while giving a Kinacort injection?
The worst that could happen was it would not work.
Exactly. I mean, beyond that, is there anything that can happen? Nothing, right?
No.
Now, always remember, if a local Kinacort mixed with lignocaine administered in the shoulder does not work, stop thinking shoulder pathology to begin with. I would never operate on a patient who has absolutely no effect after giving a lignocaine plus Kinacort in the shoulder. You understand why?
I think it is something that is coming from the very faulty posture and also the neck pathology.
Correct. So that is, you are answering every question of mine. That is exactly what you start thinking about. So Kinacot not only reduces the inflammation or the bursite in the shoulder, but also confirms your diagnosis and actually gives you a peace of mind before you undergo a procedure that you are treating the patient for the actual problem he has, and you are not shooting in the dark.
Yes.
Correct.
So
So there is nothing.
she has had a history of cervical spondylosis.
No. I'm not saying for your
So,
patient the pain may not be coming from the shoulder. I mean, she presents with drop arm test, everything related to the shoulder. So she may have shoulder pathology. But all I'm saying is, Kinacot is worth an attempt. You can always try one single shot of Kinacot, and that is what I advise in majority of my patients. Secondly, I'll just show you in this slide. So here, so just a minute. Here, if you see this, so this is my treatment for impingement, bursitis, or partial tear. What I do is I always start with rest, NSAIDs like your Nucoxia, some physio exercises, activity modification. If the primary stage is not working for 15 days, I don't advise NSAIDs for the next 15 days or for the next 1 month because it is not going to increase the bioavailability. I always go to an intralesional steroid in the second stage. And then if the patient recovers, my tertiary stage is probably delayed or avoided entirely. So I wouldn't always keep insisting on the patient to take the treatment again and again in terms of oral medicines. Now, intralesional steroid, why I'm keep insisting on this is because the location is very important. You need to give it in the either the subacromial space. If the patient has pain in the long head of biceps, you give it around the biceps, or you try and give it in the AC joint if the patient has tenderness there. So examining the patient and then giving a Kinacot is very crucial, and not just giving a Kinacot blindly along inside the shoulder. That is also very important. Okay, so this is how probably I would treat your patient, and then I would take it case to case basis.
okay, sir.
Sure.
Okay, now, I mean, I've just laid my diagnosis based on the history and treatment which has been administered. But if you ask me, I wouldn't really hurry for a surgery, or even if, see, number one, you always tell your patients, I mean, this is for all the physiotherapists who are attending, never treat an MRI. I use this statement very commonly, never treat an MRI, always treat a patient. Forget the MRI, always base your diagnosis upon your clinical examination. You guys are experts as good or even better as what we are. But always remember, always base your diagnosis on your examination and not what the MRI findings say. Okay, MRI findings will always try and make you one track minded about what the problem is. But first make your diagnosis clinically and just try to confirm it in the MRI. Don't go searching for your problem in the MRI. Okay?
Yes, sir.
Yeah. So now, your patient, the next slide, partial rotator cuff tear.
Sir, sorry to interfere.
Yeah.
Sir, I have a question. So when it is like both, when it is a tear as well as it is bursitis, should physiotherapy like simultaneously it should go on, because that would further add up to it would add up to symptoms when it comes to bursitis, right? More of activity.
Very true. So this is correct. So this is exactly what a physiotherapist must do. That a tear with bursitis presenting to you in your consulting, what would you do? You would try to reduce the pain. You would try to reduce the bursitis. You would give some ultrasound IFT and not push the patient for exercise.
Okay. Yeah.
So physiotherapy is important, but which type of physiotherapy? Then ultrasound or IFT? You try to get what I'm trying to say. So the thing is that you always try to reduce the pain and not push the patient for exercise.
Okay.
Try reduce the pain. The movement should come back on its own. Once the movements come back, then try to strengthen the muscles.
Okay. But would that add up to any kind of stiffness, because there won't be any active exercises as such?
No. In the sense, always ask the patient to be completely mobile. Number one, stiffness is a red flag sign. So if the patient, when you're trying to do an ultrasound or IFT and trying to reduce the bursitis, starts developing stiffness, then that means your treatment or whatever you are administering is not working.
Okay. Yeah.
You understand? Stiffness is basically deterioration of her problem.
Symptom. Yeah,
exactly. So stiffness is something which should not happen when you are administering any sort of conservative treatment.
Okay. Yeah.
Okay.
Yeah. Thank you.
Sure. So in a partial rotator cuff tear, rest, NSAID, physio activity, and intraregional steroid very important. So usually a patient with a partial tear, if I decide to undergo if I decide to advise the patient a surgery, I have definitely tried one or more injections. I have definitely tried a good deal of physiotherapy. I have definitely confirmed my diagnosis to be a shoulder problem. Unless all these three things are there, I don't decide to operate the patient. Be very careful. I mean, this is not a surgical conference, but be very careful before any surgeon decides to operate on a partial rotator cuff tear. Sometimes the patients, if not given good rehab exercises after the surgery, ends up in a worse position than they